So next is the Pmus. So far we discussed about the patient on not taking any spontaneous respiratory effort. If my patient taking spontaneous effort, what happened? I already told. This Pmus is 0 when the patient is sedated and paralyzed. My patient is came out from the sedated and paralyzed, patient will generate some negative pressure. So it is added to the pressure, is the Pmus pressure will be added to the P1. What happened to that? In the pressure time scalar, the pressure will decrease during your inspiration. Normally it should be like that. So during inspiration, what happened? If it is a Pmus is there, the pressure will decrease. What is the problem with this? If the patient taking Pmus, we cannot predict, you cannot identify the resistive load or elastic load because it's completely altered by the Pmus one. Second thing, the other problem with the Pmus is you can't see the stress index. Already told stress index only in the pressure time scalar, slope of the pressure time scalar. You can see only in the patient on volume control with the Square flow waveform. Patient should not take spontaneous breath. These are the 3 criteria has to meet. Then only we can see that based on the slope of the pressure time scalar, we can know patient is already or over distended or there is a space, there is a recruitment is happening during inspiration, so we can increase the PEEP. Third, there is a no need of the, if linear means there is no need to adjust the PEEP. There is a over distension means you have to come down on the PEEP. There is a recruitment is happening, you can increase the PEEP. So next is the volume controlled descending ramp waveform. Our volume control mode, when you switching on the ventilator modes, you can options will give. This is the constant square flow waveform. This is the descending ramp waveform. You can select that either waveform. So if it is a descending ramp waveform, so the same volume control, the flow will be constant, volume will be constant. You cannot change the volume or flow won't change based on the resistance and compliance because volume control, the volume is a independent variable. So you want to know the patient resistance and compliance changes from the ventilatory waveform, you have to look for the pressure time scalar. So in the first thing in the volume control mode, the descending ramp, the fuel flow will be peak inspiratory flow, what you set on the ventilator. Next, the flow will decrease and reach 0 at the end of the inspiration. Okay, but here normally in the some of the ventilator we can directly set a flow in the volume control mode. Some of the ventilator you will set a tidal volume and inspiratory time. From this inspiratory time, the ventilator will calculate the peak flow. Whatever they set, you directly setting a flow or based on the tidal volume or inspiratory time, the ventilator will set a flow. Whatever that, the peak flow will be constant in the even the descending ramp. So we see here the first is that whenever the breath started during inspiration, the flow will occur. The first pressure is contributed by resistive pressure. Okay, you see here, this is the resistive pressure. Once my alveoli are started to fill, the volume waveform started to rise, the pressure rise after that, it's contributed by both two, resistant and my elastance. Okay. So at the time of that flow is at the end of the inspiration, my flow is reaches the 0. At the end of my pressure is actually predominantly it's contributed by the elastance. There is no, because here the flow is 0. Flow is 0 means the resistive component is eliminated. So whatever that end inspiratory pressure is actually it's equal to my plateau pressure. So what are the other problems with here? Some of the ventilators we can set the flow pattern. Flow pattern here. For example, it's 50% or 25% or 30% we can set, which means that the ventilator flow during inspiration won't reach the 0 flow. Here it is 0, but here it won't reach the 0 flow. So if for example the flow is 100 liter initial flow, in this if I set a flow pattern is 0%, at the end of the inspiration the flow will be 0. Okay. If I set a pressure of 50%, flow pattern is 50%, the ventilator will decrease the pressure, so flow but it won't reach the 0. At the end of the, once the flow reaches the 50% of my peak flow, the ventilator will change from inspiration to expiration. Okay. So, why it's important for us? Whenever checking a plateau pressure, there is here in the ramp flow waveform or descending ramp flow waveform, there is no need to do inspiratory pause to measure the plateau pressure. At the end of the peak inspiratory pressure, it's a plateau pressure only if I set the flow pattern is 0%. If the flow pattern is set as 0%, the flow is reaching 0 at the end of inspiration. Whatever the pressure I am measuring, the peak inspiratory pressure is equal to my plateau pressure. If I set the flow pattern of 50% or 60%, then have to do inspiratory pause and measure my plateau pressure. So, this is very important. So, what happened to increase resistant or increase resistant? I already told that if it is the increase resistant, is that my pressure will, initial pressure will rise, because I already told this is that the first flow, the first pressure is contributed by the resistant. If it is high resistant, my initial pressure will be high. Once the alveoli started to filling, from these pressures are contributed by the both that elastance and resistance. At the end of my inspiration, the flow will be 0. So, the end pressure is contributed by the elastic pressure. If problem with the elastance, what happened? The end pressure will be high. This is ARDS, end pressure is high because of the low compliance. Here is the secretions or tube, partial tube block. So, my initial pressure is high because of the resistant component. My patient taking spontaneous breath, what happened? It gives the negative. The pressure will from the negative waveform, that is the upward concave. So, if example my patient taking spontaneous breath, we don't know that this is completely the pressure time scalar is completely altered. So, we don't know that the changes in this waveform is related to high resistant or low compliance or is just a Pmus. When the patient taking spontaneous breath, if you see some changes in the pressure time scalar, we cannot predict resistive load or elastic load. One thing is very clear, should not see stress index in the volume control mode if the patient is on descending ramp flow. The stress index only you can see in the patient volume control, no spontaneous effort with square flow waveform. Next is a pressure control waveform. So far we discussed about the volume control waveform, two different flow patterns, a square flow waveform and descending ramp flow waveform. Next is a pressure control waveform. In the pressure control, your control variable is pressure. Whatever the resistant or complaint related changes, you have to see in the flow or volume waveform. So, the first thing is that if example in the pressure control, what are the parameters you will set? Normally the basic compared to the volume control, you will set a pressure control, you will set a pressure. For example, I set a 20 centimeter water. The volume control will set a tidal volume in place of pressure control, right? So, I set a pressure 20 centimeter of water. What happened during the inspiration? For example, PEEP is 5. I delivering a pressure control of 20. So, that the pressure difference will be 20 minus 5, it's a 15. Okay. Once the alveoli started to filling, the alveoli pressure will go up, the pressure difference will decrease. Okay. So, at the initiation of the inspiration, my PEEP is 5 here, my delivering pressure is 20 centimeter water, the pressure difference is very high. So, the flow will be maximum at the start of inspiration. Okay. The pressure difference is very high. So, the volume pressure control at the start of inspiration, the flow will be maximum during inspiration. Once the alveoli started to filling, alveolar pressure, intra-alveolar pressure started to increasing, the pressure difference will decrease. The pressure difference decreases, my flow will decrease. At some point, my alveolar pressure and my inspiratory, that's 20 centimeter, will be equal. So, the flow will be 0, right? So, the flow is reaching the 0. So, at the pressure control, initially at the start of inspiration, the pressure difference is y, flow will be maximum. Then next is that pressure differences decreases over a period of time because of the alveolar filling. The flow will be exponential decay. At some point, my intra-alveolar pressure and the proximal airway pressure will be equal. There will be a no flow. So, as usual, it is the same. At the first pressure, this is our pressure control, right? It is a square pressure because it is a pressure control. The pressure is a constant throughout the inspiration. So next is that where will you change? How will you change? If it is a increased resistance or it may be increased elastance, how will you see the changes in the flow waveform? For that, you should know the time constant. Time constant is actually, it is a time required to inflate or deflate the lung. So if a time constant means, one time constant means it is the filling or emptying of lungs 63%. For example, my lung volume is 100 ml. My next volume is during expiration 100 ml to is decreased to 37. The time required from 100 ml to 37 ml is one time constant. Okay. So which means the rate of filling or emptying, which is expressed by the time, it's called time constant. Okay. Normally, for example, see here, my proportion of the equilibrium of the volume 100%, and this 100 ml. Okay. If from one time constant, the volume is decreased from 36.8. If it is zero volume, because during inspiration, the volume inflated, the volume is 63%, the lung is filled with 63.2%. The time required to 0 to 63.2 or 100 to 38.6.8. There is an inspiration or expiration or filling of the or emptying of the lung volume by 63%. The time required for to fill or empty the 63% of the volume is called one time constant. Approximately to complete the inspiration and expiration, we need at least 5 time constant. Equal to the 5 time constant, inspiration and expiration is considered as a complete. That means less than the 1% is volume left. So this is a 1, 2, 3, 4, 5. If it is a 5 time constant for the complete filling, almost the complete 5 time constant we need for the complete emptying. Okay. But approximately it is an exponential decay. So it won't reach the 0. So at least we need a 3 time constant for the acceptable inspiration and expiration. Okay. So next is a time constant is a product of resistant in complaints. Okay. So if example, it is a time constant is a product of resistant in my complaint. If a resistant increases, time constant will increase, which means that the time required to fill or empty the lung, it will increase. If it is a complaint decreases, my time constant will decrease. So which are the clinical conditions? My resistance will increase is COPD. Most common cause of increased time constant, increased resistance is COPD, bronchospasm or excessive secretion. All those conditions, my resistance will increase, time constant will increase. So that very few, there is rarely my complaints will increase, especially in emphysema, complaints will increase. So there is no other reasons for increased lung complaints. Complaints commonly will decrease, resistance commonly will increase. So if anything, if we see the increased time constant, which means that increased resistance. Okay. If example, resistance won't decrease, normally resistance, all pathological condition, your resistance will increase, won't decrease. Okay. So the complaints, if ARDS, what happen? My complaints will decrease. So anything you see the short time constant, most likely it's related to decreased complaints. Prolonged time constant, this means that increased resistance. So if it is increased resistance means it's most likely it's obstructive airway disease. If it is a short time constant means it is a ARDS, most likely ARDS or pulmonary edema, pneumonia, all those conditions, complaints will decrease, so time constant will decrease. If it is COPD or increased secretions, all those settings, what happen? Resistance will increase, so the prolonged will increase the time constant. So increased time constant means increased resistance. Short time constant means it is poor complaints. So what you see the example, this is the example of, this is the normal lung, normal time constant. Okay. For example, 0.6, 100%, one time constant is 0.6, two time constant is 1.2. So, for example, I already told ARDS is a conditions with low complaints conditions. So, time constant is resistant in complaint. If complaints decreases, my time constant will decrease. Compared to the 0.6 time, what happened here? Time constant is decreased from 0.6 to 0.4. Okay. If it is that, if other way around, if it is COPD, it is a obstructive airway disease, my resistance will increase. So, resistance is increased here. It's a time constant product of resistance and compliance. So, my time constant also will increase. Time, for example, normally is 0.6, say ARDS is 0.4, here it is 1.3, it is increased. So, in the COPD, resistance is increased, so time constant will increase. In the ARDS, my resistance, my compliance is decreased, my time constant is decreased. So, how will you know that? How will you identify from the pressure or volume waveform it is resistant or compliance? So, I already told and this is the flow waveform. Okay, already there in the pressure control, the flow will be exponentially decay. Okay, is exponentially decay at reach the 0. Okay, if my resistance is very high, okay, what happened to here? I need a longer time to fill the lung. If example, my time constant is 0.6 seconds. So, I needed 3 times of my time constant, it is 1.8 second for the inspiration, okay, to fill the lung. If my, because of the resistance by something is that bronchospasm, my time constant is increased from 0.6 to 0.8. So, if I need to fill the lung to complete the inspiration, here I need 1.8 second, here is I need 3 times is 2.4 seconds. Okay. Here the inspiration will be prolonged. Okay, here compared to this is prolonged. So, my here this example, normally my inspiratory flow is here, this is the way. Because of the resistive load, my inspiration is prolonged. Okay. So, if it is other way around, here is a resistive problem, elastic load related problem. It is a pulmonary edema. My compliance is decreased. So, time constant is resistant into compliance. So, compliance is decreased, my time constant also decreased. Okay. Normally, it should be, waveform should be like that. Because of that, because of the poor compliance, my elastic pressure is increased. So, time constant is decreased. So, ventilator waveform will be rapidly reaches the baseline. So, if it is a prolonged a resistive related problem, it will take long time to reach to fill the lung. If it is the poor compliance related, the ventilator will fill very rapidly. So, it reach the baseline, the flow waveform reach the baseline very rapidly. Okay. So, next is the Plateau pressure. How will you mean the pressure control? Volume control, we all know that you should put an inspiratory pause and measure in the square flow waveform. In the volume decreased RAM flow waveform, you no need to put a pressure control. If your flow is reach the base 0 at the end of inspiration, whatever the end inspiratory in peak pressure is your Plateau pressure. In the pressure control, normally you won't check the Plateau pressure, because whatever the pressure you are giving, it is your Plateau pressure, right? It's P plus your pressure control. For example, in the pressure control, I set a pressure control of 12, my P is 5, my Plateau pressure is 17. Okay, pressure, because pressure is the independent variable, but which is not always true. Why it's not always true? I will tell you that. Here, my flow is 0, right? I set a pressure control of 15. This is my P is 5. So, my peak inspiratory pressure at the end of the inspiration is 20 centimeter water. So, almost that at the end of inspiration, the flow is 0. The resistive component is eliminated. So, whatever the pressure, the peak inspiratory end inspiratory pressure is equal to my Plateau pressure. So, the peak inspiratory pressure 20 centimeter water. So, Plateau pressure is 20 centimeter. So, it is normally peak inspiratory pressure, you will take it as a Plateau pressure. But what happened to that? Some of the conditions, we won't set a appropriate inspiratory time, or because of the resistance, my inspiratory flow won't reach the 0. For example, this is the normally, I told the pressure control of 15, P5. So, normal lung, so the ventilators, the flow is reached 0. So, whatever the pressure measured here, 20 centimeter water is my Plateau pressure. If it is other way around, my resistance is increased now. Okay, what happened to that? The flow, normally it has to reach 0, but it takes longer time because of that high resistance. The lung taking a long time to fill the lung, so it's not reaching the baseline of 0. Okay, because the inspiratory time is ended, so it moves to the expiration. When I checking a plateau, I cannot take my end inspiratory pressure here as my plateau pressure because my flow is not reached 0. Okay, so if you take it as your pressure control or P pressure as a plateau pressure, you have to see the flow time scalar. It's reaching the baseline of 0 or not. It's not reaching 0. Actually, it's not a pressure control P pressure. Whatever the peak inspiratory pressure is not your plateau pressure. So next is the effect of expiratory flow. So what happened to that? All our expiratory flow waveforms are passive, irrespective of the pressure control or volume control. It's a passive process. Expiration is a passive process, right? So normally your expiration will be exponential decay based on the time constant. It's try to reach the baseline. It's a peak level. Okay, normal. If my resistance is high, what happen? The patient, that expiratory flow waveform will take a long time to reach the baseline. See here, this is my normal passive flow curve. Okay. When the resistance is increased, my time constant will increase. So when the patient need longer time to, the expiratory flow waveform need a longer time to reach the baseline. Because of the high resistance, this is a increased resistance, prolonged time constant, the ventilator, the flow waveform is not reaching the baseline at all. That's why we need a long expiratory time in a COPD patients. Okay. So if it is a ARDS related, there is a decreased compliance, the short time constant, the ventilator, the expiratory waveform reach the very rapidly the baseline. Normally it has to reach the baseline here. In the resistance, it's not reaching the baseline at all. In ARDS, it reaching the baseline here. It's a short expiratory time. Sometimes patient will be active expiration, the waveform will be completely altered. So you cannot know there is a decreased compliance or prolonged time constant or increased short time constant. We don't know it's decreased compliance or increased resistance. The patient, there is no active expiratory effort. We can know from the expiratory flow waveform, we know it is a increased resistance or decreased compliance, all this irrespective of my pressure control or volume control. Next is the step 1 is the tag. Steps 2 is the determine the load. It's a predominantly resistive load or elastic load. Third, step 3 is the diagnosis of patient-ventilator interaction, which means that synchrony, asynchrony or dysynchrony. Synchrony means that Pmus means patient respiratory effort, P-vent is ventilatory inspiratory pressure, start and end at the same time, which means that it's a synchrony. Pmus is a reference signal here. Asynchrony means absence of one signal. In example, a failed trigger means there is no P-vent. Example, Pmus, when patient want to initiate the breath, generated some Pmus, but ventilator not delivered the breath. It's called failed trigger. False trigger means that P-vent, without patient respiratory effort, ventilator thinks that patient taking breath, then delivered a breath. It's a false trigger. These things are called asynchrony. Dysynchrony means P-vent start and end at the different times. P-vent, normally the Pmus and P-vent will be in the same time. The P-vent before the Pmus, it's called early trigger. If the P-vent after the Pmus, it's a late trigger. So the third step, the patient-ventilator interactions, synchrony or asynchrony or dysynchrony, we'll discuss in the separate class. So first I'm summarizing here, the ventilator waveforms are as very important like ECG for the ventilated patients. All our ventilators, the modern ventilators will give the continuous real-time information about our respiratory mechanics. The recent study showed only few of the consultant working in a critical care is actually interpreting the ventilator interference waveform appropriately. It's less than 5%. The ventilator interpretation of waveform is very important. There is a 3-step in the ventilator interpretation. First is the mode. What type of mode? It's a tag. In this tag, there is 3 things are control variable, breath sequence and targeting scheme. Step 2 is the determine the load, which means that know that from the volume control, you will see the pressure time scalar, what is resistant or compliance and stress index. In the pressure control mode, you will see the flow time scale, we know that from that we know it's increased resistance or compliance. Irrespective of the pressure or volume control mode, always expiratory flow waveform is the passive process. From this expiratory flow waveform, we know it is increased resistance or increased compliance. The first step is tag, second is determine the load, it's increased resistance or compliance. Third is the interaction, asynchrony or dysynchrony, asynchrony, we will discuss in the separate class. Thank you.